Thank you for all joining us for today's webinar. My name is Todd Pittman, and I'm excited to introduce our speaker today. A bad system will beat a good person every time. Healthcare is a system that is getting more complex, causing providers and their teams to be burned out, practices to lose reimbursement, and patients to be less satisfied. Processes and workflow are the foundation of every good system. Kari Kalgren's passion is processing and helping others understand how to build a better, sustainable workflow. The director of K2 Health, Kari's team provides training solutions to physicians' practices and life science companies. Topics like buy and bill, efficiency and infusion suites, value-based care programs like MIPS, and applying Lean Six Sigma in a practice are just a few practical topics they teach teams to think about from a real-world, process-focused perspective. Kari started her career in practice in healthcare, then spent time working in the industry with specialty drugs and infusion suites. For the past 4 years, she has been training others to build strategic processes that make sense for patients and providers. On a quick side note, we want to thank Kari for her flexibility. She was a scheduled presenter at the annual North Carolina MGMA conference, but due to a schedule mishap, only had approximately 6 minutes to present. Kari, thank you for understanding and offering this webinar to us today. Please welcome Kari.
Thank you, Todd, and it's great to join you all again today, as it was in Wilmington as well. So I'm looking forward to having a few more minutes to dive in a bit more in some of the details. We are really interested in looking at waste, efficiency, and processes, and really about how you can make that very practical. We've heard often that people have said to us, we hear sometimes about, strategies and ways that we should be thinking about becoming efficient, but we never really get some practical tips on how to start doing it. So we're really focused on giving you those things so that you can start using them as early as this afternoon if you want to. So let's just dive right in. The objectives, we really want to make sure that you understand how to look for different kinds of waste in your practice, and we'll go through the 8 most common types of waste. We really operate on a thinking called lean thinking, which a lot of you may have heard about. It really originated from the Toyota production system, so we'll talk about those wastes and how you can find them. We want to talk about also getting to the root cause of the problem. I think a little bit harder when I'm on a webinar, but typically live, I'll ask for a show of hands. How many of us have done things in the past where we kind of got halfway down the road and realized we may not be trying to solve the correct problem? So we really want to help you start thinking about what kind of tools and how to think about getting to those root causes. And then we'll go through some of these tools. So when I typically give this talk, I'll have a variety of people in the room, sometimes physicians, sometimes medical staff, and also the practice managers or administrators. And I'll ask, how directly does workflow or process impact your profits? And I have a hunch that the majority of the people on this line today, if we were in the room, all hands would be in the air saying, we definitively know that these workflows and processes do impact our bottom line. But the question that I want to ask and follow up and have you all be really honest and candid with yourselves is, how consistently are you verifying that that workflow design is actually impacting your profits? So if somebody said to you how much or in what way, or you had to get real objective about it, could you say that I know what we're doing is the right thing, and these are sort of the nouns and the numbers that can explain it? And so I think if we're all honest with ourselves, there's typically a little bit of a gap between the first question and the second. And that's what we really want to focus on today, is to help give you some of that objective data, ways to find it, and have those answers if somebody would ask you. So let's just start quickly with a little bit of a setup of what we're dealing with right now. And as you all probably know, healthcare is extremely expensive. In the United States, it's about 18% of our gross domestic product, which is, about $3.3 trillion. And this is similar to the entire GDP of the nation of Germany. So around the time of the Affordable Care coming out, the Affordable Care Act, there was this concept called the triple aim, and this was really brought forth by Don Berwick and some of the staff at the IHI, saying, here, we need to have this model, and we need to really address the cost of healthcare in the nation. So 3 main tenets, think of this as kind of a 3-legged stool. The three legs are population health, the patient's experience of care, and then cost or value. Great model. We're all trying to achieve this, but a new paper came out just a couple of years ago from two physicians at the AMA, and they said, despite the fact that this is a great model, the triple aim, there is a missing leg of the stool, and that missing leg is called clinician experience. We are not able to achieve the triple aim if the clinician experience is poor. And in the paper, you can read that clinician experience is defined as both the physicians, but also their staff. And I think I mentioned this saying at the meeting in Wilmington that in South Dakota, where I grew up, we had a saying that kind of went something like this: if mom is not happy, and I'm sure you can fill in the blank here, no one's happy. And I say that a lot in practices because I do believe that if we've got burned out physicians at the top, this sort of has a trickle down effect, right? So what do these things look like? What is the burnout and what is the cost of actual burnout in a practice? So as you look down this list on the left, we know that this can impact the patient, their satisfaction. How are they engaging with the practice? Are they returning for visits? Are they having no-shows? Are they adhering to their treatment plans or their medications? If the physician's burned out, the staff are burned out, the patients can feel this too. We know that in chaotic practices where there is a lot of burnout, there's a lot of errors. Some of the proactive things don't always get done. This impacts your teamwork. And recent data that we've seen, which is probably a bit conservative or a little bit low, shows that the average cost to replace a staff member is on average for a medical assistant $22,000 nationwide, or you can look at about 150% of that staff's annual salary. Then on the physician side, again, probably a bit conservative, but nationwide, average cost of physician, and this didn't go into certain specialties, but average cost to replace a physician is $250,000. So burnout has costs, and I know that you all as administrators of your practices can feel that and know that. So how are we going to create practices and situations that we aren't having some of those feelings of burnout? When you talk about the quadruple aim, the practices that truly understand value-based care, how to engage their staffs around that, trying to provide a good patient experience, and combining that to be synergistic with the policies that are out there. So we know there's a lot of things happening right now for practices with programs like MIPS, trying to align all of your efforts, to be more synergistic with your workflow. These are the practices that will thrive in this current landscape of healthcare. So let's move forward, though, to talking about getting started and what does this look like. The unfortunate thing is it's sort of, a human nature thing that when we want to fix something, we sometimes tend to go to the fastest, easiest, least painful solution instead of always the best solution. And this is human nature. We have all done this before. It's very demotivating as a human being to be faced with uncertainty. As human beings, we just avoid it at all costs. It's just very much part of our nature, our DNA. In fact, there is cultural studies that have been done to show that the number of people that do nothing versus doing something is very frequent. It's part of the human behavior. So we're very hesitant to want to put resources at risk, and change is usually all about risk. So the method that we use at K2 Health when we train is we use a standardized approach to process improvement. And you can see it here on the screen. We call it the ARAM approach, or assess, recommend, implement, measure. Today, we're going to focus on just the first portion of it, assess and recommend. People often say to me, when you're in chaos, it's hard to even know where to start and how to get out of that, how to create a plan. And so we'll talk about that in a minute. How do you know where to start? And then number two, how are you currently determining that you're starting at the right place? I've seen practices very unintentionally, with all the best intentions, get started right away, but aren't taking those first few kind of pauses or moments to put a strategy together to think, what are we looking at? What is our root cause? So as I mentioned before, we work off of the lean approach, or the Toyota production system sort of mentality of thinking. And before I go any further, I would like to say that I've seen a lot of hospital systems or practices be involved with lean. It kind of ebbs and flows over years of the practice. And there's been practices I've seen who've implemented it fantastic, and then some people just implement a piece or two. So if you've been in a situation before where you've been exposed to maybe lean or implementing some sort of a lean approach and potentially had a negative experience, I would urge you to just try to come back to a neutral place with lean and just know that lean is a way of thinking. It's a management style. It's trying to remove waste and really ultimately get your team members involved to create a culture of problem solving. So that said, there are 8 wastes in healthcare and that lean really talks about. And the 8 categories are waiting, motion, inventory, overprocessing, transportation, overproduction, defects, and the one that's listed here in green is human potential. And the reason that I listed it in green is that this is one that I see often, almost in every situation that we go into a practice to help do training, we see some sort of a waste of human potential. So it could be somebody not working to the top end of their licensure or certification. I see this often with physicians, maybe doing tasks that somebody else could be doing besides the physician. Their time really should be spent on tasks only that they can be doing. I also see it with you all, with practice managers and medical group managers, really wanting to be in a place where you can chip in and help out. But again, are some of these tasks things that you can do to delegate to others to free yourself up to do some of the more critical tasks that only your role or your position can do. And so I've got an example for you here in the next screen. This was a great one because this came out of a rheumatology practice. And we've worked with practices across the United States. So we've been in some really interesting scenarios, everywhere from Bozeman, Montana to Chinatown and downtown New York City. We've seen a lot of things. This is an interesting scenario because at the time that MIPS was being introduced, the rheumatology practices were really starting to say, what are we going to use as our disease activity measure, something consistent we can use in all of our patients to meet a certain quality measure. So you all likely have something similar. I know in the psych offices they're using a PHQ-9, et cetera. So everyone's got this sort of standardized instrument they use to assess activity in patients. In this certain setting, the Rapid 3 is the instrument that's used. And if you look here on this screen, assuming that there's about 44 weeks of the year that you're in clinic, compare from the physician, the middle column, to the certified medical assistant on the right. And this kind of goes back all to this idea of burnout that we're talking about and what is the cost of burnout, right? Or the cost of workflow inefficiency. If you think that you've got an MD doing a Rapid 3 in every single patient that comes through the door, they were telling me that they only spend about 10 seconds to compute the Rapid 3. So we did a time analysis study and we observed several different scenarios of timing this. And the reality was that it was not taking 10 seconds. That was the perception. The reality was that it was taking about 45 seconds in total once they received the instrument to the time they counted up all the different numbers. So if you're doing a Rapid 3 in every patient, and you in collective got about 3,300 assessments you're doing a year, this then equals about $5,500 a year in costs that we have MDs spending their time counting up 1 to 10, 3 different times to find the Rapid 3 score. So it becomes then a thing of who do we want to be having doing this task? And again, that goes back to the idea of human potential. Are you working at the top end of your certification or your licensure? And is everybody in your practice doing the same? So if you take that another step further, then consider this. If you were going to be saving that 41 hours a year from the physician spending his time calculating Rapid 3s versus having somebody else in the office doing it, what could you do with that extra 41 hours a year? And what does that look like? So again, this is about looking at finding waste and really quantifying it to determine, is this the right improvement project that we want to work on or something that we want to do in our practice? So in this particular practice, we were working with them. It was 30 minutes is what they have in their template for a new visit, 15 minutes for an established patient visit. And we are just assuming 80% productivity in that 41 hours of savings we found. What could you do then, or what does this do for your practice to be able to have a new patient visit per week, or just under 2 patient visits for established visits a week. Or how else could you utilize the time for the provider? So these are things to think about and how you can start to quantify what waste actually means to your bottom line. Okay, moving on to the next section. So my husband always laughs at me, but whenever the cleaning people come to our house, I have to clean up before the cleaning lady comes. And that's kind of what I'm asking you to do in this first step, is that in offices often we need to clean up to see. So in Lean, we talk about going to the Gemba, and the Gemba is just the real place or the actual place. It's a Japanese word, but what it really means is go to the source to find the facts, to help you make better decisions, to build consensus with your team, so you can more effectively achieve your goals. So in your situations or scenarios, this means going down to the clinic floor, going to where the work is happening. Maybe it means going to the front office, or even sitting as an observer in your waiting room to understand what's going on and what's really happening. Too often, we find that people think they know what's happening, or they might query their staff or ask a question and take that information for granted, assuming it's true. And this is not to say that anyone is trying to spread false information, but just our perceptions are different. And every time that I go to the Gemba and I observe and see, I learn something new, even if I think I already know what the process is. So I encourage you to spend time to go to the Gemba, and if you can't do it, maybe have somebody, a third person, somebody more objective, come and observe and make those observations about what's happening in your workplace. So you have to clean up to see. If you're presented a picture like this, let's just say that there was a cut or an injury that somebody had, how could you even begin to determine what might have been responsible for that error, that mistake, or that injury? And so part of the concept of cleaning up to see is so that you can see the variances and the abnormalities more quickly and identify them. If you think back to, if any of you have spent time in the operating room, we've done some work in the ORs, you'll see the trays of tools that come out that actually have outlines for each tool laying on the tray. And it might not be that you need to get this granular in your practice, but there are very good reasons to make sure that there's not errors being made. For instance, in the OR, before the patient is closed, we want to make sure that all tools are laid back out and accounted for on that tray. So the point of the pictures that I just showed you is really to illustrate that you have to straighten up to see, so that you can see where all those abnormalities are occurring when they do occur. We talk about it often as a 5S event, and so we'll even facilitate these in practices at times. The 5 S's stand for sort, set in order, shine, standardize, and sustain. And we can often do sort of a red tag event with this. So going through all the different things in your practice. We did a observation kind of facilitation event with materials management at a small hospital. And that was an interesting activity because there were so many different pieces of equipment and tools on bookshelves and things around that really truly weren't being used anymore. They were obsolete, they were scrapped, they were defective, they were dirty. So it really trying to organize what materials we needed to have and making room for other things. So I encourage you to do this, and even if you did it in just chunks throughout your office. We worked with a small practice. It was actually a dermatology practice, and they were just reordering office supplies whenever they couldn't find something. Come to find out, just having a small space in their administrative area to lay out in baskets all the different office materials. They had a lot of waste and things that they were ordering, several ink toners and several things that were expensive they didn't need to be ordering. So not all of these things may impact direct patient care, but again, directing your idea and your thinking around looking for waste and finding ways that it can impact your bottom line in the practice. Okay, so setting standards. When you say standards in a clinician or physician's practice, people sort of kind of tense up, and I see their shoulders raise up and get a little bit tense when we say the word standards. Standards is not to say that everybody should be doing everything exactly the same way all the time. I think that sometimes physicians get frustrated and say, you want us to be kind of like a manufacturing line or an assembly line. We can't practice medicine in a cookie cutter fashion. What we are trying to say with standards, just like in the cleaning up pictures I showed before, is we want to give them guidelines. And so I always try to describe this in the terms of parking a car. I want them to get between the two white lines. And as you can see in this picture, we're clearly not in standard here. But I don't care if they back in or pull in forward or have a red car or blue car. I want them between those two white lines. And so I think that, the idea of standards can be somewhat kind of claustrophobic feeling for certain clinicians, but it's our jobs as the people helping them to make sure they understand what they are and why they need to be there. This is something that I see often when we talk about quality measures and reporting for MIPS, making sure that everybody understands what the standard is, but also what is the outcome or the consequence of being outside of the standard. And oftentimes we may know what that is, but the staff may not, or the staff may have turned over and somebody didn't realize that by not collecting a certain quality measure and documenting that in the structured data field and the electronic health record, what does that consequence have, and what can that do for the practice overall if they're not collecting that information? So standards is getting between those two white lines and making sure that we're telling everybody why we need to do that, and then what is the consequence if we're not in those standards. Next up, we have determining the root cause. And so again, we really want to make sure that if we're going to spend time and resource on something, we are working on the right thing. And I'll just cue this up with telling you a story. We're working with a group in the Charlotte area, and they had a really good idea, something they wanted to try out. The front office administration wanted to try out a new process. And there were a few people on the team that were maybe not so sure, or they were a little bit hesitant about change. And so they said, well, here's what we're going to do. We're going to try this new process out. And then it was around scanning and bringing in documents into the electronic health record. And if you don't think that it works in 2 weeks, you can let us know, and we don't have to continue to move forward with it if it doesn't work. So hold that story, and we're going to go ahead a few slides, and then I'll come back and tell you how the story ends as we move further along the presentation. All right, when variance occurs and we are working outside a standard, here's some questions you can think of and use to kind of start thinking about why did the mistake, why did the variance or abnormality occur? So did it happen because we didn't have a standard? Did it happen because the standard wasn't followed? Or maybe did it happen because the standard we had is not adequate anymore? So it could have been appropriate a few weeks ago or months ago, but things have changed and evolved, and we might need to update that standard. It may not be adequate anymore. Some people say, okay, Kari, but we really think we're going to work on this project, or we know we need to increase efficiency in other areas, but we don't have standards. How do we know where to start? Here's another slide with some questions you can ask yourself to get your mind kind of thinking and generate some ideas to root cause. What could you do to optimize efficiency and workflow in the practice? So what's preventing somebody from leaving the office to get home on time? How long do patients have to wait to get new patient appointments? If somebody quits tomorrow on your staff, would your team be able to cover that gap easily? Or do you have your physicians heard them say, you know, I feel like I'm spending more time clicking in the EHR or measuring these quality measures. It's taking me away from patient care. Hearing these things should put a red flag in your mind and make you start to think about, well, what is that waste that's causing this, and can we identify root cause? So if you're looking for something to work on and you don't know where to get started, maybe go back to some of these questions. In addition, you can also refer back to those 8 wastes that I mentioned before and start organizing your thinking around those different 8 wastes. So let's go through those in a little bit more detail. So waiting could be waiting on some sort of upstream process to deliver something to you, or some sort of a queue. So a more specific example could be, do you have lots of patients kind of piled up waiting in the waiting rooms? Or I've seen scenarios where people go from the front waiting room and then they have to come back and give a urine sample, and then they're waiting in another waiting room, which is getting really bottlenecked. Or they're presenting to the lab afterward and there's a huge queue of patients waiting there. If this is a problem for you, it might be something you want to start diving into. You could also look at it on the other side of things. Do you have ancillary staff who are waiting on patients. So they're really kind of waiting with nothing else to do. And I've seen this with our phlebotomists waiting for patients to present back to them. So in the meantime, I'm seeing them on Facebook or I'm seeing them on their phones. They're really sitting idle. So this could be also another example of waste of waiting in the office. You've got the idea of inventory, and I'm sure right away you can all think of things that are happening, and sometimes it's not necessarily even on purpose. We had a practice that started a new, more esoteric send-out lab, but in the meantime, what they didn't think of was they were ordering on a routine order reagents for the labs they were doing previous to this new lab. And because the new lab test was a send-out included 2 different lab tests they were running in their own practice, they ended up getting this extra inventory or waste of reagent that was piling up in the lab area. So think about all the things that might be piling up. It could be inventory of extra office supplies, but lots of probably places and scenarios and practices where inventory is a waste. Transportation, so depending on the size of your practice or how it's laid out, are patients being moved from room to room? Are you constantly moving medications or supplies around? If you have infusion suites, are you constantly moving, medications, mixing in one location and then moving them to another? What are all the things that are moving constantly, and is that creating some sort of a waste? And defects, probably a common one is more on the billing administration side. So do we have incorrect coding? Do we have clean claims? Is there something happening in the practice around that that we can address and be more efficient? The last 4 wastes, let's see. There we go. Overproduction. So are we getting unnecessary diagnostic tests or potentially ordering meds the patient may not need? So are we really looking at the updated medication list every single time, or are we sending something to the pharmacy that doesn't need to be sent? You can even look at it as in terms of your staffing. Do we have peak staffing during non-peak hours? Is there a bit of a waste there? Can we adjust hours? Are we doing prior authorizations on multiple biologics? An example here is that we had a provider say to his team, his administration team, go ahead and do the benefit verification for these 3 different products for the patient. And then once we see what the benefits come back like, then we'll decide which agent we want to have the patient go on to. What the physician didn't realize was that to do that for 3 different products was extremely time consuming. And so we had to do some education and draw out a new swim lane kind of process map to help them identify which agents they would start with first to reduce some of that overproduction of work by the staff. Motion, another one, a little bit different than transportation, but again, talking about your workflow, where your supplies are stored. Do you have things in cells around your nurses' stations or centers? Are the right staff members co-located so that they can talk to one another easily? How do we look at motion and how do we kind of arrange things differently so that there's less waste? Overprocessing. This could look like performing additional tests on a patient, even though there's something more simple. So could we do an x-ray instead? Doing unnecessary paperwork. We see a lot of times offices will send out new patient packets to offices. So they're spending a lot of time photocopying and folding, stuffing envelopes and creating address labels. When they really kind of dig into it to see how many patients present back with their paperwork, it was a very low percentage number. So they had to identify and think, do we still need to do those new patient packets, or do we just need to do a portion of it? Can we use our portal somehow? But they were really realizing that that was a lot of waste that they spent, both financially, but also in human potential time filling these packets. And then we talked a little bit about human potential already, and looking at that example with the Rapid 3, are people working below their level of licensure? Do you have clinical staff, nurses, RNs, or LPNs doing prior authorizations when you could potentially train somebody without that license of nursing degree behind their name, have somebody else doing those administrative tasks? Okay. Or maybe you're the individual on the line right now that says, I don't need ideas trying to find where to eliminate waste. We already know where our wastes are, or we already started a project but now I'm not quite sure this is the project that I should have started. I didn't do some of these exercises. I didn't think maybe what was the real root cause of this, or I'm finding out something differently as we got going. And that's okay. Before we talk any further about that, though, here is a quote that I share often with people, and I think it's really sound advice. Don't cling to a mistake just because you spent a lot of time making it. And unfortunately, I do see this a lot. So you, as the leaders and the managers of your groups, if you can set the expectation for your practice, for your office, that we are creating a culture of problem solving, and with that, we might make mistakes. If that happens, it's okay, but don't cling to the mistake just because you've spent a lot of time making it. So if you've already started a project and you're not quite sure that you were doing the right thing, here are some really nice core questions to assess your progress. So you could say to yourselves, the team, are we achieving the target goal that we set out to achieve? And if we are achieving it, is it occasionally or is it consistently? Are we improving? So can we predict future performance? How do we improve? So when do you react? When do you say we're going to take a step back? Maybe we're going to pivot. And then the big thing here is how can we prove that we've improved? Again, back to nouns and numbers. Is it objective? Having the nouns and numbers forces us to get real honest with ourselves about the progress of our continuous improvement projects. So essentially what we're saying is, do we have the right tool, right problem, and do we have the right solution? And here are some of the tools. We're going to kind of shift now to talking about some of these different tools in terms of what you can use to maybe identify different wastes in your practice. So I won't read all of these to you, but there's a variety of tools listed on this chart. Some of you may have used some of them or all of them before. We've put them together into a table for you, which I think you have the slides available to you. And as you look at this table, the way that it's set up is the waste type is over on the left column from the top down, and then going across on the top are these different tools. And so if you're trying to identify what waste might be represented by different tools, this will help you kind of start to whittle it down and think about which tool you might want to use first. So before we get into the tools, we call charts the voice of the process. And so kind of just a cautionary note here that when you start to collect data and nouns and numbers, we can sometimes tend to get really excited about data and all this objective information. So put it into a chart. It doesn't have to be on Excel if you're not comfortable with Excel. It could be a whiteboard. It could be a notebook. But I do encourage you to document it. But it's much easier to see when you kind of draw it out in a chart. What are you seeing? What is that chart telling you? When you look at this on the left, this office wanted to say, okay, what percentage of patients are we getting a urine sample completed before the appointment? They set out a target goal. They wanted to hit 75%. And on the week of June 5th, they had hit 66%. So what does that even tell you though, right? So here's where the chart kind of becomes the voice of the process. And again, you don't have to use Excel. You can, plot this out on a piece of paper. But if the target is 75% and you look at these 12 different weeks or these different data points, it appears that the current process is not going to allow them to reach their target of 75% because there's fluctuation. So do we need to adjust our process? Is something not quite getting us to where we need to be? But again, I think you can see visually here, the point is to plot out those numbers to really tell a story about what's going on. Also, regarding responding to changes in metrics and those fluctuations and up and downs, it's really easy and it's really tempting to want to react right away to some of those numbers. The challenge here that you're going to have to challenge yourself as managers and leaders is to react less and think about improving more. So when you see some of those fluctuations or something out of variance or abnormalities, ask these questions. What went wrong last week or last month, whatever you were measuring? What was different about that time period? Are we improving or getting worse? And again, that predictability. Can you predict future performance? So back to the tools then, because we're trying to get some of this objective data. The Gemba walk or the time motion analysis. And again, I've heard some managers tell me it's really easier for me to have somebody objective come in. So you might need to do that. There might be that scenario where your staff perform differently when you're watching than when somebody else might be watching. So, but to walk around with a timer, I use my iPhone, and I always use pencil because I'm always constantly erasing things, changing things, taking down notes, but do it again by walk and just observe the processes in your practice. It's very insightful. And again, I encourage you try not to take people's word for things and really go see for yourself and go to that Gemba. We've got worksheets and electronic tools that I'm happy to share. If you would like them, just reach out and I can send these to you. But there's different worksheets that we've created for these go and sees or these Gemba walks as you do a waste walk through your practice. And it kind of helps you organize, again, the wastes by those 8 wastes of lean. And so in this worksheet, you can write down what you're observing and then what kind of waste does it correspond with, as well as any follow-up or items that you think of right away that might help that process. Kind of a brainstorming sheet as you go through the Gemba and do that waste walk. Another tool, the 5Y exercise. So this is an example from a very, very large practice. They had 11 providers and about, I would say, 23 or 22 exam rooms. And the challenge was it was causing a lot of stress between the physicians and their clinical staff, but also a lot of stress between the clinical staff and the front office. They were kind of all pushing on one another. And the problem was that the patients were not in the rooms when the physicians went to meet them. So the 5Y exercise is really challenging you and your teams to dig down 5 levels to get down to root cause. So in this example, this is what we did. So why are the patients not in the room when the physician is ready? What we found was, well, wait, why does the physician think the patient should be in the room? When the front office would open up the encounter when the patient presented to the front window, what it was automatically doing in the electronic health record was putting a line through the patient's name, what the physician saw in the back. So in the physician's mind, there's a line through the patient's name, which means they're checked in. They should now be in the exam room, waiting and ready for me. But in reality, what happened was it just meant that the front office staff opened up the encounter, and that line through the name happened immediately. And there were several steps that had to still occur. They had to get paperwork, they had to collect copay, and then the medical staff still had to call them back and room them. So why does the physician think the patient's in the room? Because of the line through their name. Digging down another layer deeper, why is the rooming process from the waiting room to the exam room taking so long? What we discovered was the MAs kind of had this interesting order in which they would call patients back. And it wasn't always necessarily by their appointment time. It was because they were kind of all waiting for one another in the hallway. It was real narrow. So the MAs had their own sequence of who went and called patients back at what time. But then we kind of dug into that further and said, well, why did you guys ever create this sort of sequence of when you called patients back? And the reason is because this clinic with 22 exam rooms and 11 patients only had 2 places where they could weigh and measure patients. And so the hallways were so narrow, the MAs had kind of just inadvertently created their own system around this, and they only would call a patient back at each time to not get in one another's ways. So at the end of this exercise, what did the practice do? They purchased more stadiometers and more scales and tried to put them in the exam rooms as often as possible. So they didn't have a full 22, but they got up to something around 18, which made this whole process much smoother. Not to say that the EHR wasn't a training opportunity, but we probably never would have gotten down to the root cause of needing more scales and stadiometers had we not done the 5Y exercise. Okay, so just to kind of follow up on this, another exercise is so what? And this is a little bit more, not so much finding your root cause, but then saying, what are we going to do about it? And if you think of the 5Y exercise as drilling down 5 levels, so what's kind of coming up those 5 levels then? So what would happen if we did adjust the EHR and then come up another level? What would the impact be of distributing patient loads throughout the day? What would happen if we changed patient exam rooms for 2 providers to be closer to the front of the clinic who saw more patients? So all these different things that could be solutions do the so what kind of coming up after you've gone 5 layers deep on the 5 whys. Make sure that you're working on the right root cause. And this will highlight a lot of things in your discussions. The next tool is the Pareto Chart, and so some of you may have used this. If you're proficient with Excel, you can make beautiful charts like on the left, but don't worry that if you're not proficient, you can do this very simply. And there's one example where lab tests and imaging results were not being attached back to the patient's record electronically. And so the physician was getting up out of the exam room, kind of looking out down the hallway and asking for his staff to, reactively go find these tests. They might be in the scanning pile, where were all these results? And so what we wanted to find out was, why was this happening? So we made a simple little post-it note here on the right that you can see the different reasons of why they were not being attached back to the electronic health record. Sometimes they were back at the practice, but not entered. Sometimes they were just never received back to the practice. Sometimes they were attached back in the wrong place in the chart, so it was there, but maybe a staff member put it in the wrong field. Sometimes the wrong test was ordered, and then sometimes just the patient never presented to get those labs or that test done. It was just not performed. So we wanted to find out what was the main reason, and then we were going to address that reason first. As you can see here, this is kind of where the 80-20 rule comes from as Pareto charts. The majority of reasons it was not there was that it was not entered. So it had come back to the practice, but it just wasn't entered. So we knew definitively from this exercise, this tool, this was the improvement project we were going to address and work on. We talked a little bit about that rapid 3 example at the beginning of the webinar, and just how do you calculate the economic impact of workflow. And so a really simple tool that you can use, this is available online, and it's through the AMA. It's a website called stepsforward.org. And so you can go onto one of the modules, and this calculator's there several different places, but you can put in approximately what you're paid and what your staff is paid, and you can calculate either a minute of your staff's time or a minute of your provider's time, and then what some of the savings might be. I have worked with physicians before where the practice administrators had said several times over, we really want you to employ this new process, and for some reason couldn't get the physicians there. And I know that this happens a lot where the same person, somebody else can come in and say the exact same thing you've said, and maybe it will hit them a different way, but this might be a way to try it. Tell your physicians, hey, look at it this way. What is the economic impact of a minute of your time worth? So if you want them to be doing another task instead of a task maybe that they could have somebody else do in the office, this calculator might be helpful for you. The Fishbone Diagram to determine root cause is a great one. You can get your team around a table or a conference room to do this. We've even done it in front of class windows and just given everybody a packet of Post-it notes. And we'll talk about the disruptions to getting patients roomed on time. That's the example here. So what are all the reasons that people think that this is happening? And you can have everybody just free flow brainstorm their ideas and put these Post-its on the window or the wall or wherever it is that you're working. You can even do it in a hallway if you want to. And then what you have them do next is you start to categorize these Post-it notes into these groups. Is that a people issue, a process issue? Is it a materials and equipment issue, or more of an environmental issue? And not to say that you're going to be able to address every single one of these things, but it's really thinking broadly about what all the different reasons could be, categorizing them into groups, and then by kind of lumping those Post-it notes together, you'll be able to draw a fishbone diagram like you see here, and really start to hone in on where you think you can be most effective and what's going to be most impactful to your bottom line. Okay, another one here is called the value stream. And so in this one, what you can do is you can look at all the different things, all the different steps that take place for a patient to go through a process. Or you can even change this and say not about a patient, maybe it's a certain piece of paper that's being touched multiple times by multiple people in the office. What's the true value creating moments of that cycle that it goes through? If it gets touched 5 times, but 3 of the times are not creating value, do you need to have those steps? And at some points you might say, yes, that's one step that it doesn't create value, but we have to have it. And that's okay, then you keep it in your process. But it might bring to light and help you highlight certain things you never would have considered. I really don't know why we're doing that anymore. We started that process 6 years ago because we had a different EHR system at the time, but now we don't need to. We just kind of carried that forward and didn't realize we're doing it. The same way you can look at patients. Consider the entire value stream and really try to think about too, not just the times they're in your practice, but is there something happening from the referral place to you, to long-term management, or looping that referral back? What is the entire value stream? And are there steps in the process that may not make any sense? If there are, if they're the NVA or the non-value added steps, try to remove them if possible. This is a really fun one. It's a spaghetti diagram, so you can even just take a picture of your fire escape map on your hallway and just print it out and sit in one spot and just watch the motion occur. Take a pencil or a pen and just trace out the motion that's occurring in your practice. If it seems chaotic and it seems hectic, find out where then all the bottlenecks are. And after you do that for a while, you'll start to see sort of all the motion where it's collecting or where there's barrier, and you'll be able to identify better why is it happening in that particular space. And the reason this one's called a spaghetti diagram is because it looks kind of like a plate of spaghetti once you draw all those lines on it multiple times. One of the most common tools that we use is a process map with swim lanes. And I'll tell you that most people, when we say, do you have definitive swim lanes, just definitive roles for all your staff to know what they're working on each day, a lot of times we'll get the response back. People will say, well, we really have to multitask because we're a small office. So people have to do 2 or 3 different roles. And that's okay. I like the idea of multitasking and being able to fill in for one another. What is your role that day? Or for that particular task, what is your role for that task? So think about that and think about drawing out process maps and swim lanes. So in this kind of example here, talking about the front desk role versus the medical assistant's role versus provider in terms of seeing the patient on an office visit and then thinking about prior authorizations and the handoffs that are occurring. And it really helps you determine who's doing what in the practice. If you have a hard time drawing process maps, a couple different tips for you. Sometimes it's easier to start with the future state, the ideal state of where you want to be, and then going backwards and drawing your current state and then looking for the gaps. Where are the things that are not quite matching up? I always say try to start with the current state and look for your opportunities, but if you can't quite do that, it's just a little bit too overwhelming and you know where you want to be, then go ahead and start with that future state and then work backwards from there. Org charts. This is something we often don't see in small practices. They kind of assume that we're a small practice and we don't really need an org chart. Everybody sort of knows one another here. The challenge becomes in terms of waste when there's people doing duplicative things or there's maybe some arguments between staff. A lot of times just having a clear org chart and saying, here's who you need to report to, or if you have a question or an issue, this is sort of your line of your chain of command, and here's how our organization is laid out to really sort of hone in and say, here's where everybody should be in the practice and try to eliminate some waste in that capacity as well. So hopefully those tools are helpful. They can get you thinking. Some of the most common pitfalls that we've seen in practices I've got listed here on the right. So just having unbalanced workload, again, peak flow times, maybe not having peak flow scheduling of staff at those times. We had a practice where we evaluated their workflow and they had 87 people coming through the doors, which is almost 70% of their visits for the day between 8:30 and 10:30 a.m. But they had the same amount of people at the front desk the entire day. So we had to look at how can we balance the workload to offset some and make it a bit more efficient for the entire practice. Do you have the right people in the right place doing the right task? Look at your staff's skill sets and are they in the right places? Somebody who might be great with patients may not be great in the administrative area or vice versa. Do you have SOPs to share best practices or learnings? Sometimes SOPs can be a little bit daunting. It feels like something that we all know we need to do and spend time documenting, but it's not really fun and nobody ever really has the time to sit down and do these SOPs. So again, practice manager, administrators, physicians should not be creating these. That's not where you should spend your time. What you could do is you could say, I'm going to use a webinar technology or even your iPhone with the camera. I'm going to record and show you what I'm doing and talk it through. Then hand it off to a staff member and let them memorialize it and write it down in a checklist or an SOP for you. Oftentimes it's going to change by the time someone gets it done anyway. So there's some ways you can kind of work that and make it a little bit more efficient, but get those done. Again, there's lots of different unpredictable workflow, inefficient workflows in the labs, high rate of turnover. These are the most common things that we see. And it really goes back to the thing here. The waste type is listed on the left, that these all go back to one of the 8 wastes of lean. So just kind of a cute picture here, but really think about this picture when you start to work on something. Oftentimes we are all kind of focused on the little bird on the shoulder of the hippo, but are we really truly solving for the correct problem in our practices? So just to summarize, process does impact profits definitively. You need to get to the workplace, get into the Gemba, go see for yourself, and you need to straighten up and standardize before you really get started solving for the problem. Once you think you've got the right thing, make sure, check in. Did I use a tool? Do we have the right process? Do we have real objective nouns and numbers to make sure you've got the right thing that you're solving for, the root cause? And if you've got nouns and numbers that you already determined to help you find out what the root cause is, you should be able to then use those metrics to be indicators of your success as you get started. And again, that's something we can talk about at another time, but to have those metrics to measure your success and stay accountable is so important. So I told you I'd tell you the follow-up to a story that I introduced earlier, and that was that when they came back to the staff to say, did the new scanning process work, there was 2 individuals of staff that just didn't really want to do the new process. So as you can imagine, regardless of how well that process performed, what do you think the answer was? And the answer was, no, it was not working. So what they did on the second time around was go back and put some metrics to that and say, how many times did we have more than 10 pieces of paper in the bin? And they really couldn't come back and say, after 2 weeks of doing it again, they didn't have that happen or occur. So they were guided then by metrics to know that the new process worked, instead of letting subjective opinions about it guide what the next improvement project was. So think about that, and if you have any questions, I'd be happy to entertain those right now. I want to thank you for letting me jump on this webinar with you, and again, open to any questions.
Kari, thank you. We're going to leave it open for just a moment to see if there are any questions. At this point, we do not have any questions. So we'll give it just a moment, and if you have a question, and if you can type it in. I don't think we're seeing any questions. If you have any follow-up questions, I encourage you to email Kari directly, and her information's been provided. But we thank you today, Kari, and we appreciate the tools that you provided us that hopefully most of us will take these away and find ways to utilize them in our practices. And we thank everyone for joining us today.
Thanks for having us, Todd.
We do have one question. People are asking if the slides will be available, and they will be posted to the NCMGM website for members.
All right, well, thank everybody.
Thank you.